expanding treatment options for glycemic reduction in patients with type 2 diabetes. Please, Francisco.
Good afternoon, everybody. Thank you, Bertram, for your kindly introduction. So it is difficult, to come after Bertram and to say any aspect new from the presentation, but I would try to go into details about the glycemic reduction effects from SGLT2 inhibitors and, the perspective to use these drugs in patients with type 2 diabetes. Here are my disclosures. So the topic I will explain to you is the role of SGLT2 inhibitors in the treatment of patients with type 2 diabetes. And I want to try to translate to you why I think this new class is important to treat patients with diabetes, what are the specific beneficial effects from this drug, and when we have to use and also the results in terms of efficacy and safety. In terms of why, well, you know that many patients around the world, not only in Europe, but also in the States and in other parts of the world, are not able to achieve the goals. So you see here the data from the cost of diabetes in Europe to a study. You see that approximately 69% of patients were failed to achieve the goals of an hemoglobin A1C below 6.5%. When we are looking at the more recent panorama study, in which the patients were included in different European countries, you see that approximately between 30 to 40% of patients were not able to achieve the goal of an hemoglobin A1C below 7%. And why is that? And that is probably related to the natural history of type 2 diabetes. In patients who are impaired insulin sensitivity or increased insulin resistance, you know that the decline in beta cell function are able to translate these patients for the prediabetes to the diabetes states. And with that, came the glucose increase over the time. And for many patients, we know that with not correctly treated hyperglycemia, that we have an increased risk of microvascular complications. But for some patients also we know that even in the prediabetic stage, these patients have macrovascular complications. Therefore, I think to prevent the translation from prediabetes to diabetes is also important to treat these patients appropriately, but also to delay the deterioration of the metabolic control in patients with type 2 diabetes, we need also treatment intensification. In fact, if we are looking data from the UK-PDS, you can see here that for those patients, for example, randomized to sulfonylureas after 2 to 3 years, for those using glibenclamide or copropamide, hemoglobin A1C rose over 7% over the time. The same is for metformin after 3 years, and you can see the same figure even for insulin after 6 years. So many patients will need to use treatment in combination to achieve and to maintain the glycemic targets. In terms of the benefits of the intensive treatment, all you know that from the UK-PDS and afterwards for the UK-PDS and post-trial monitoring, you know that for those patients achieving intensified withdrawal at the beginning of the disease, like in the UK-PDS patients, you can see benefits in terms of microvascular reduction, and these benefits maintain over the time. In terms of all-cause mortality and also myocardial infarction, not shown in this slide, you see that the benefits of intensified treatment at the beginning of the disease will take some time, and then you will see also benefits in terms of reduction of all-cause mortality. And therefore, many authors, and this is a nice slide from Stefano Del Prato, many authors and experts, they say that, okay, this is very important to achieve a very good control at the beginning of the disease, and trying to reduce at least the risk of the chronic complications that can occur over the time, and not to go step by step, using additional agents only when hemoglobin A1C is over the targets or maybe over the 8% as shown in this slide. So what about the role of SGLT2 inhibitors in the treatment of patients with type 2 diabetes? Well, all you know these figures, and this came from Raul de Fronzo, in which they show very elegantly that beside the classical factors or mechanisms that are behind the development of type 2 diabetes, as the impaired insulin secretion, the decreased glucose uptake or insulin resistance, and also the increased hepatic glucose productions, there are other aspects that probably play a major role also in the development of hyperglycemia in type 2 diabetic patients. In particular, decrease in incretin effect in the gastrointestinal system, increased lipolysis due to insulin resistance at the fat tissue, also increased glucagon secretion, as has been mentioned before by Gottman, and also neurotransmitter dysfunction that's associated with insulin resistance at the level of the brain. And more recently, we're speaking about the increased glucose reabsorption, as has been shown before. That's an important mechanism in patients with type 2 diabetes. And therefore, we have different agents that can be acting at the different levels, and it's not surprising that, as can you imagine, for many patients we have to combine different agents with complementary mechanism of actions. I will focus in my talk about the SGLT2 inhibitors. As you saw, they are selective inhibitors of the glucose co-transport SGLT2 at the level of the nephron. So certainly, one size doesn't fit at all, and many patients are different, and therefore we need different agents, and we need also to manage appropriately the different combinations to treat all patients with type 2 diabetes. So regarding SGLT2 inhibitors, you can see here on the slide, and we are focusing on the three drugs so available in Europe: empagliflozin, dapagliflozin, and canagliflozin. They differ, as you can see here, in their selectivity against SGLT2-1 and SGLT2 transport. And as you can see, the most selective one is empagliflozin, and the less selective will be canagliflozin. I will go further into this aspect. And in terms of the potency related to fluorescein, you see the more potent will be dapagliflozin, and then empagliflozin and canagliflozin have a similar potency. The mechanism why these drugs act has been explained previously. This is another slide to say the same things. You know that in patients with type 2 diabetes there is an increased glucose reabsorption for the mechanism explained before by my colleague. So drugs like SGLT2 inhibitors decrease the renal threshold for glucose, and that means that even in healthy subjects this level will be reduced below 70 to 90 milligram per deciliters. So, that means that even in the fasted state, we will see patients with glucosuria. So this is a study performed in patients with type 2 diabetes treated with metformin and also placebo or canagliflozin, dry 100 milligrams. And you can see very nicely here that the increase in the glucose excretion, this occurs very, very quick, even at the first week, and this will maintain over the time. That means that these people excrete between 80 to 90 grams per day of glucose. And although you can say that numerically the urine volume will be increased at the beginning of the treatment, then this aspect, becomes more comfortable for the patients, and the increase in volume at the end of the 12 weeks was not so much higher. In terms of canagliflozin, because there are some effects, especially when you are using high doses of canagliflozin, more than 200 milligrams. You can see here, and this has been done in healthy subjects, that the postprandial plasma glucose for those subjects using more than 200 milligrams of cana, the postprandial glucose will be decreased as compared with lower doses of cana or placebo, as well and the insulin serum levels. Although, as you can see here, in terms of the urinary glucose excretions, the results were very similar. And some people are thinking that this is probably, and this is an hypothesis to be proved, still to be proved, that the higher doses of canagliflozin will play probably a role in at least to control the postprandial glucose after the first meal, after the breakfast in this case, due to transitory inhibition of the SGLT2 at the level of the gastrointestinal tract. Another aspect to be commented is the effect of this drug in terms of the beta cell function. Probably you know that results in rats have demonstrated that decreasing glucosuria improved beta cell function, but this should be also demonstrated in patients with type 2 diabetes. And there were patients treated, as you can see here, with metformin plus sulfonylurea, and you have here, after a mixed meal tolerance test using C-peptide and glucose dynamics, it was possible to define the insulin secretion rates in comparison to CANA 300 milligrams as compared to sitagliptin 100 milligrams. And as you can see here, that in both cases, after the treatment from baseline, there was an improvement in the insulin secretion rates, and this improvement was very similar, comparable between CANA 300 and Sita 100. But if we are looking at other surrogates, as for example the HOMA beta or the proinsulin C-peptide ratio, you can see a small but statistically significant improvements with canagliflozin 300 as compared with sitagliptin 100. That means that even these drugs improving hyperglycemia by increasing glucosuria, they were able also to improve beta cell function. But the question is, if the mechanism of action of these drugs are independent of the beta cell function, it will be nice to demonstrate that the effect of this drug will be similar independent of the remaining beta cell function. And that has been done by Matthew and colleagues using data from different phase 3 trials. And as you can see here, they take people from 4 different phase 3 trials, and they divide the patients in different subgroups according to the beta cell function, low, mid, or high beta cell function. And also they divide also these patients according to the baseline hemoglobin A1C. And as you can see here very nicely that obviously for those patients with higher hemoglobin A1C, there was a major effect of CANA 100 and CANA 300, but in general you can see that the effect was completely similar irrespective of the remaining beta cell function. The same you can see here in this group and also for those with a baseline hemoglobin A1C below 7.5%. That means that the effect of this drug is completely independent of the remaining beta cell function. And the same is analyzed in terms of the HOMA-IS as reflecting the insulin sensitivity, and you will see here that irrespective of low, mid, or high insulin sensitivity, again in this analysis, the results of the benefits of this drug are completely independent of the insulin sensitivity status. And finally, to confirm this data, this is a very nice article from John Williams sitting here, that they also analyzed 4 different trials, and in terms of the diabetes duration, less than 5 years, 5 to 10 years, or more than 10 years, and you can see here that the results in terms of the efficacy and the change in the hemoglobin A1C was completely the same. So that means that these drugs are across the natural history of the type 2 diabetes. Let's move now to the placement of this drug and the efficacy data from these drugs in the treatment algorithm. All you know that the ADA-ESD algorithm 2015 is an improvement from previous algorithm, but there is no hierarchy in terms of what is the second line agent or the third agent to be used in this case, because after metformin we have different choices, and one of them included in this algorithm is SGLT2 inhibitors, and also it can be used also in triple therapy in combination with sulfonylurea, glitazones, DPP4 inhibitors, or even insulin, but there is no particular recommendation to which agent to be used in a particular patient. Therefore, it's important to be sure that we need to individualize treatment depending on the other characteristics from patients. But certainly, for example, the Americans in the American Association of Clinical Endocrinologists algorithm, you see here that in this case, SGLT2 inhibitors have been placed in the second place, both in the dual therapy or in the triple therapy. That means that these agents, at least in the algorithms, are gaining an important place in the different therapies to be used in treating patients with type 2 diabetes. Regarding glycemic reduction, and these are placebo-adjusted change from baseline in terms of hemoglobin A1C. You can see here that Cana, DAPA, and empagliflozin in monotherapy seems to be slightly more effective than in combination with metformin or with insulin plus minus or other oral agents. You will see minor differences. It seems that canagliflozin could be slightly more effective, but we don't have any head-to-head study to compare the different agents between them. In terms of canagliflozin, you will see here the reduction of hemoglobin A1C in different trials, in monotherapy, in dual therapy, in addition with metformin after 12 weeks or 55 weeks in triple therapy or in combination with insulin. And you can see here that at least canagliflozin seems to be very effective, in monotherapy, and also as compared to CETA with metformin, it seems to be even slightly more effective. So the efficacy in comparison with glimepiride is the same. And in triple therapy, canagliflozin was not inferior, but also superior as compared with the additional sitagliptin in patients treated with metformin plus sulfonylurea. And finally, in combination with insulin, it seems to be that the reduction was very low, but you can see that these patients had CKD disease, and you can expect a slightly less reduction of hemoglobin A1C. I will comment on that later. Regarding dapagliflozin, same picture. So major reduction for those patients starting initial dual therapy, as in this case, similar efficacy in combination with metformin as compared to glipizide in combination with metformin, and also important benefits in terms of the combination with PIO or in triple therapy or in combination with insulin. In terms of empagliflozin, similar picture. You can see here slightly more effective than CETA. In combinations in dual therapy, you can see here that more effective than placebo. Even after 104 weeks, more effective, slightly more effective in combination with metformin as compared to glimepiride plus metformin. And in patients with triple therapy, also the addition against placebos more effective. Also in this case with pioglitazone. And also EMPA had two studies, very nice studies in combination with basal insulin for those patients using basal bolus therapy, and you can see an impressive reduction in combination with insulin. In terms of the change of the fasting and the postprandial, you can see here in this study, which CETA was compared to CANA in triple therapy, you can see here very nicely that CANA reduced significantly more the fasting plasma glucose as compared with sitagliptin, and also there was a higher reduction, although not significant, non-significant in terms of the 2 hours postprandial glucose. In terms of patients, for example, with CKD, you can see here in this particular study from Jamut that the reduction of hemoglobin A1C was significant, although in magnitude less than as what I have shown before for both 100 and 300 milligrams of canagliflozin. But if we analyze patients with a stage 3A or a stage 3B CKD, then you can see here that for those people with glomerular filtration rates below 45 ml per minute, that here the reduction of hemoglobin A1C is much lesser. Therefore, it has been recommended also by the health authority to use canagliflozin in these cases with moderate impairment function for those with glomerular filtration rate higher than 45 ml per minute, as well as for empagliflozin. This is not the case for dapagliflozin. As you know, it cannot be used below 60 ml per minute. What about the glycemic reduction as compared to other non-insulin agents in combination with metformin? So you have here on the left side DPP-4 inhibitors, on the right side SGLT2 inhibitors. You can see here, at least from what we know at the moment, that probably the reduction of MOL1C is slightly more important with SGLT2 inhibitors. For GLP-1 receptor agonists, important difference in terms of those with long-acting GLP-1 receptor agonists like dulaglutide, exenatide, extended release, or liraglutide, higher or more impressive reduction of MOL1C, less impressive with albiglutide and also with exenatide. Exenatide is not shown in this picture. What about the adverse effects related to the use of these drugs? I will start with hypoglycemia and then I will comment other adverse effects. So you can see here that intrinsically this agent, when used in monotherapy or in combination with other agents with low risk of hypoglycemia like metformin, you can see here that the proportion of patients with hypoglycemia are really very, very low. We see only hypoglycemia in combination with sulfonylureas or insulin, as has been shown in this slide. If we go by any of the drugs with canagliflozin, you can see here nicely that the most important hypoglycemia rates will be found in those patients treated with sulfonylureas or with insulin. The same picture for those patients using dapagliflozin, and again the same figure for those patients using empagliflozin. So no increasing risk of hypoglycemia with these drugs, but when you are using in combination with a drug that predispose patients to have hypoglycemia, then the hypoglycemia rates are higher. What about other side effects relating to these drugs? I will comment only very briefly those events with a proportion higher than 2%, because, for example, volume depletion related events have been reported between approximately around 1%. So I will not comment on that. But if you see here in this slide, there is an increase 3 to 4 times in the frequency with female genetic mycotic infections, and also, as you can see here, the same, although the rate was much lower, in males for genetical mycotic infections. In terms of the urinary tract infection, a slight increase, but the meta-analysis are conflicting. In some cases there is a slight increase, in others there are no statistical significant differences. But in any case, the proportion of patients having urinary tract infections are approximately similar to those has been treated with placebo. Regarding dapagliflozin, the same picture, so higher frequency of female and male genital mycotic infections, and also similar figures for those patients using empagliflozin. To summarize this aspect, I would say that the genitourinary urinary infection is really it is possible, and patients should be monitored, and also, in my opinion, at least what we did in Spain, in my office, at least we inform patients that this can be possible. Usually these infections occurs at the beginning of the treatment and will be only a single infection, and usually they respond very good to the treatment with antimycotic agents. In terms of the increased LDL cholesterol, this is also controversial, and there is a small increases between 5 to 10%, but my friend Ronan will discuss this in much detail afterwards. In terms of the bladder cancer, numerically there has been informed that there was a slight increase, so a disbalance in in the bladder cancer for those patients using dapagliflozin, as well as an increased numbers of patients with breast cancer. And in the labeling, dapagliflozin is not recommended to be used in patients with active bladder cancer and should also be used with caution in patients with a history of bladder cancer. And finally, as I told you, so generally these agents should not be used below 60 ml per minute, but empagliflozin and canagliflozin can still be used until 45 ml per minute. What about bone safety in SGLT2 inhibitors? Probably all you are, or most of you are aware that last week, on 10th of September, the FDA published a warning for canagliflozin related to the increased risk of bone fractures and added new information about decreased bone mineral density. So what is behind this information? So I tried to make a statement at this moment, because probably we need more data in the future, but I can tell you that bone fractures with dapagliflozin were more common, but only in patients with moderate renal impairment. As you know, they are predisposed to have more fractures, but not in those with normal or mildly impaired renal function. In addition, there is a particular study in which John participated over 2 years, and they will measure different bone markers and also BMD, and there are no meaningful changes related to the use of dapagliflozin after 2 years. What about canagliflozin? Canagliflozin has been reported there is a small increase in bone fractures. So we are speaking about 2.5% for those using Cana 100, 2.3% for those using Cana 300, and 1.7% for those using placebo or active comparators. But particularly, this is a very interesting study that has not been published, but the results are available in the web page of the clinical trials. And in this trial, data from 26 weeks in patients who have a mean age from 63.6 years, so they will include patients from 55 to 80 years old with type 2 diabetes, and they found no changes in the percentage change in the lumbar spine, distal forearm, on femoral neck bone mineral density, and only, as you can see here, only marginal variation in total hip bone mineral density. And finally, regarding empagliflozin, there has been a pool analysis from all phase 1 and phase 3 trials, and there were no increased frequency of bone fracture at all in these patients treated with empagliflozin. So, you know, at this moment, we can say only that this issue is controversial, and we need more data to be sure if these agents are not related to an increased risk of bone fractures and decreased bone mineral density. So, to summarize this part, so we can say that these agents are neutral in terms of hypoglycemia. They bring a benefit in terms of weight loss. You know, we have the problem of genital mycotic infection and also increased LDL cholesterol slightly. But they are also neutral in terms of the gastrointestinal side effects, no problems in terms of congestive heart failure at the moment, and also, at least from the colleagues of the American Association of Clinical Endocrinologists, neutral in terms of bone side effects. So to conclude then, I would say that hyperglycemia in type 2 diabetic patients may result from different mechanisms. SGLT2 inhibitors reduce hyperglycemia by increasing urinary excretion independently of the remaining beta cell function. SGLT2 inhibitors are effective and safe also in monotherapy and in combination therapy with other oral agents and also insulin, improve both fasting and postprandial hyperglycemia, and can be used in patients even with moderate renal impairment, CANA and EMPA, until, I said before, a GFR over 45 ml per minute. These agents do not increase per se the risk of hypoglycemia, but enhance the risk of genital mycotic infection, especially in women. And finally, these agents may be used across the whole spectrum of type 2 diabetes, and therefore, in my opinion, they expand the treatment option in patients with type 2 diabetes. This is my final slide, and you will see here that it's not only important to consider the glycemic control, but also other factors like the risk of hypoglycemia, the beta cell deterioration, if patients they are overweight or obese, and also other factors as cardiovascular risk. And I hope that John, in his presentation, will deal with the clinical cases about how to individualize treatment in patients with type 2 diabetes. Thank you very much for your attention. And then I will introduce my colleague, Ronan. He will speak about the non-glycemic effects of SGLT2 inhibitors.
Thank you, Francisco. Here are my